Hi, this is Brian Kim. I'm going to share with you case number 42 in the Best Way to Do Cataract Surgery series. This is a white cataract, somewhat of a dense lens. I'm going to show you efficient lens disassembly using double chop, cross chop, mechanical fracturing forces, crushing the lens pieces between the chop and the fingertip. This reduces ultrasonic energy. This is an efficient way to be able to grab pieces out of the bag, pull pieces up in atraumatic fashion. This is very safe on the zonules. This is the easiest way, in my opinion, to perform lens disassembly. So I'm using a cotton tip to help center the eye, and then I'm using the corneal mark to help me center and size my rhexis. This patient's eye is belling up towards the left, so I'm able to make a nice flat incision with my paracentesis blade. I have to coax the eye towards the right, which is pointing downward, to do my other paracentesis incision. You want to be flat to the iris plane, parallel. This creates a nice corneal shelf so that I can have a nice self-sealing corneal incision. I'm injecting some intracameral lidocaine and now some dispersive viscoelastic to inflate the eye and coat the corneal endothelium. I'm going to use a cannula to control the eye as I do my triplanar corneal incision. I make a vertical groove, put the blade into the deep part of the groove, turn the eye away from me, tunnel through the cornea, turn the eye towards me, and then enter, and that's the triplanar corneal incision. Again, I'm able to manipulate the eye using the cannula. This is my puncture style capsular rhexis. I puncture centrally, pulling down towards me, grabbing the right edge of the tear, and I'm able to create a flap. I'm going around circumferentially, trying to follow the corneal marks that I made previously, which will help me to center and size the rhexis. You can see there's quite a bit of opacified lens material there, which is obscuring my view just a little bit, but I decided not to use trypan blue in this case. Going around circumferentially, grabbing and re-grabbing, and I'm able to complete the rhexis, decompress the eye. And this is the capsular fornix hydrodissection technique, placing the cannula out to the equator, going underneath the anterior capsular rhexis edge, pointing the tip down, getting a nice fluid wave, decompressing on the left side, and then on the right side, you can see I'm able to rotate the lens. The lens is spinning nicely. Interestingly, as I do this, it brings up all this white cortical material up into the anterior chamber. So I make sure that my tip is the right length. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. I'm removing the surface epinuclear material. Place the chopper out to the contralateral equator, rotate the phaco tip vertically subincisionally, crush the lens, and dividing it completely in half. That's the double chop maneuver, placing the chopper out around the right heminucleus, pulling it centrally towards the phaco tip, and that's the cross chop maneuver. That first quadrant came out quite nicely. I'm placing the chopper around the second quadrant, pulling it towards the phaco tip, crushing that fragment, and then prolapsing the second part of that second quadrant up, and then crushing it and using ultrasonic energy and vacuum. I'm turning the second heminucleus in front of me, placing the chopper out, pulling it centrally, meeting the phaco tip, which is placed deep in the bag, crushing the girth of the lens. Remove that third quadrant fairly nicely, doing the same maneuver, placing the chopper out, pulling it centrally, meeting the phaco tip, which is deep in the bag, crushing the girth of the last quadrant there. Using mechanical fracturing forces to break down the lens pieces, and then using high vacuum and a little bit of ultrasonic energy to remove the lens pieces. I'm just trying to remove some of that epinuclear material. I decided to go underneath that epinuclear shell with the chopper, lifting it up. But then at this point, I just decided just to go ahead and come out. So I take the chopper out, push BSS in, take the phaco tip out, and then place the INA handpiece in. And I begin removing the epinuclear material, starting sub-incisionally, and then working on the left side. You can see that the epinucleus and cortex came out quite nicely. And then I'm polishing underneath the anterior capsule rhexis edge, switching to the polish mode. And I can be very aggressive when I do this because even though I have the pedal all the way down, the aspiration and vacuum are very low. Once I polish the anterior capsule edge, I start to polish on the posterior capsule surface as well, removing any visible lens material that I see. And then sweeping underneath the anterior capsule edge some more. So using a BSS cannula, I'm going to pulse in the subincisional capsular fornix area to make sure there's no hidden lens material. It's pretty clean there. And then I'm going to use the cohesive viscoelastic cannula to fill the capsular bag, and then use the capsule sweep to polish the anterior capsule surface. First on the left side, and then switching to the right side. And whenever the lenses are potentially larger, when they have white cataracts, I'm always mindful of the capsular bag and zonules, so I prefer putting 3-piece lenses in these cases sometimes. So I widen the incision to accommodate this larger cartridge, going in, using the capsule sweep for counterforce. Facing the bevel to the left, I'm delivering the lens. The leading haptic is pointed to the left flat and parallel to the iris plane, is going into the capsular bag. And then I'm dialing the trailing haptic in with the Maltzman. I go in with irrigation off, inflate the eye, and then I'm going underneath the optic, rotating the lens, making sure both haptics are in the bag, as well as removing any viscoelastic from within the bag. Polishing underneath the anterior capsule edge. And then removing the viscoelastic in the anterior chamber. So I'm going to push some BSS into the angle, make sure there's no hidden viscoelastic, and then I'll hydrate my incision. So this is a white cataract, not a dense cataract, but enough of a substance that requires lens disassembly using chopping forces. I'm using double chop, cross chop, mechanical fracturing techniques. I'm able to reduce my use of ultrasonic energy with these maneuvers. You can see this was not a rushed technique. I was able to systematically break down this lens very confidently, very efficiently. In my opinion, this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.